devoted to temporomandibular joint disorders. So my practice is dedicated totally to orthodontics and to temporomandibular joint disorders. And I'm living in the marvelous city of Odessa, and this is situated on the Black Sea. This is Ukraine, and this is our famous famous opera theater. And this is the city of Dubai that you all know, and this magnificent view from, I think, from the helicopter. So this is a few words about me. I want to mention two researchers that influenced my work and my both practical and scientific. This is John Drotter in the upper part, in the upper photo. He's the dentist from the US, and he's working on TMJ, and he has conducted a lot of studies, and he made a specific classification and step-by-step examination of the TMJ, and he is a brilliant practitioner, and he inspired me on doing what I'm doing. And the second person which I like and which I think has inspired me also not less than John is Dr. Robert Kirstein. He's the dentist from the US, and he's dealing mainly with the T-scan occlusal analysis, which I'm using since 2011. So these people are those who inspired me on giving this lecture and on my work, which I'm doing, which I'm currently doing. So temporomandibular joint disorders, and this problem is not that aesthetic, and we cannot see it just on the surface and immediately. And what we're doing more functionally. We're influencing the patient more functionally, and the results of our work are seen afterwards in one appointment, in two appointments, and they're not just seen when we're positioning kind of an implant or crown. So the more we learn, the more we intrude, the deeper we intrude into the knowledge, the more we're left to learn, because all the muscle chains within the human organism, they are all gathered together, and all the muscles, they are joined together. The temporomandibular joint is underestimated, and this is the only joint, I want you to know that this is the only joint in the human organism that works without rest. And all the human functions, like swallowing, like breathing, like speaking, they're all conducted with the use of the TMJ. And even when we're lying and even when we're sleeping, it works, it still works. So this is the only joint that has the maximum load in our human organism. Yes. The prevalence of the temporomandibular disorders, this is your topic, doctor. Yes, it is reported to be more than 60%, and this is reported in the previous studies, and I want you to notice that it is very high in the population. And what we see is seen by the symptoms and by the clinical signs, and the other problems that are not reported by our patients and that are not diagnosed by the doctors are still left unreported, those issues. So how can we determine these signs and symptoms of the temporomandibular disorder just from the start? How can we do that? We do that even without seeing the patient's teeth. We can just have a look at first glance at the human face, at the patient's face, and we can have those markers on the human face which will tell us about the presence of the temporomandibular joint disorder. So first of all, this is the facial symmetry. When we look at the patient's face, almost in 80% of cases, we will notice facial asymmetry. So when we look at this pretty girl's face, we see that her left side is a little bit shorter. We see that her right side is shorter, and her left side, we see these outlines, and they're different. When we try to combine her eyes, we see that her eye contour, still being on the same level, we see that her right eye is a little bit larger than her left eye. This is the second sign of her facial asymmetry. When we go further, we see that the alar part of the nose is the same on the different level. And the higher is the alar part of the nose, the more the masseter muscle is trying to contract. And this is the sign of the right part, of the smaller right part of her face. Then we go down to zygoma, to the zygomatic arch, and we see that her zygomatic arch on the right side is still lower, and we see that her masseter, which has the origin on the zygomatic arch, is trying to contract and is pushing her right side down and making her right side smaller. When we go and try to superimpose the muscular structures of the head on the facial outline, we see that the main muscles that are working within the temporomandibular joint are the temporalis muscle, the masseter muscle, and two pterygoid muscles, the medial and lateral pterygoid muscles. And these muscles, which are partly joining the facial muscles, the muscles of facial aesthetics, they are all making the face look the way it looks. So when we have the hypertonus of the masseter muscle, it will influence all of the facial muscles and the circular eye muscle and the circular mouth muscle. TMDs were reported to be in the higher prevalence in class 2 division 2 malocclusions. And then the studies shifted deeper into the understanding of the occlusal relationships, and they reported that the retruded contact position and intercuspal position shifts are also related to the presence of the temporomandibular joint disorders. These all were reported by the university studies maybe 20 years ago. But now, when we're going deeper and deeper into this knowledge, we see that the temporomandibular joint diagnosis has to be a step-by-step procedure, because a lot of structures are involved into the functioning of the temporomandibular joint, and all these levels have to be examined separately and step by step. And what I'm going to talk about, I'm going to talk about the step-by-step procedure of the temporomandibular joint examination and diagnosis. And I want to notice that all the structures within the TMJ have to be diagnosed and examined separately. And we have divided all these structures into 4 main levels. We have divided them into the teeth level, the level of the chewing muscles. The next level, this is the level of the TMJ soft tissues, which includes capsule and the ligaments of the temporomandibular joint. And finally, the 4th level is the level of the TMJ hard tissues. We may consider the teeth level to be the most changeable level, the level that we are interventing with our dental treatment. This level is influenced every day at every appointment, and this procedure of step-by-step examination cannot be utilized not only by orthodontists, but by general dentists and by the specialists of every type of dental intervention, orthopedists, therapeutists, etc. Because the prevalence of the TMD in the population becomes higher as we misdiagnose these temporomandibular joint disorders, and especially orthodontic treatment makes the prevalence even higher, because the studies have reported that after orthodontic treatment, the number of TMD has become higher. This happens because the practitioners misdiagnose these TMDs before treatment, before the start of treatment. We're not diagnosing TMDs before the start of orthodontic treatment, and we're conducting orthodontic treatment, making the patient condition even worse. So that's why this procedure can be utilized to diagnose temporomandibular joint disorders and to make even the first step examination, just to note that this condition presents, just to make the patient aware of this existing condition. So first, teeth. When we examine teeth, this is just a brief outline of the procedure, making the emphasis on the main things concerning the levels. When we examine teeth, we look at the distribution of tooth contacts, we look at the number of contacts per arch, we look at the right and left side balance, we look at the time of occlusion, we look at the time during which the teeth tend to disocclude, and all that influences the next level, the level of the chewing muscles. When we examine the patient, we can diagnose with palpation and with further instruments like surface electromyography instruments. We can diagnose the low or high tone of the chewing muscles. We can compare the tone of the symmetric muscles from the right and from the left side, and we can diagnose the presence of the myalgic pain in the patient. When we examine the soft tissues of the temporomandibular joint, we can, by palpation, we can, of course, also note the presence of the ligament laxity, the presence of the inflammation of the retrodiscal tissues, and the range of motion, which is influenced by the ligaments. And the TMJ hard tissues, of course, can be diagnosed only with the use of the X-rays and cone beam CT. So this will be, I will talk about it later. So this is the main levels of the examination and the main things that we do during our routine examination of the patient. This is what we do every day in our clinics when we examine a TMJ patient, and we have recently we have started to utilize this procedure to examine each orthodontic patient that comes into our office. So the first step, of course, is the patient's history. The patient's history is a 15-page examination history, the questionnaire, which is filled in by the patient, by himself and herself. Then we're taking the photos, the intraoral and extraoral photos, and then we go step by step examining the patient with the use of this the far-level concept examination procedure. First step is the T-scan examination procedure that examines patient's tooth contacts. The next step is the joint vibration analysis, which examines the function of the temporomandibular joint. We combine it with surface electromyographic instrument and examination, and then we go to TMJ CBCT and TMJ MRI. MRIs are the last step in the examination procedure, which are necessary to make the final diagnosis. Without MRIs, we cannot make the final diagnosis of the patient TMD, temporomandibular joint disorder. So the history of the when the patient fills in the history, he tells us about his main complaint, about the type of pain that exists. Usually, temporomandibular joint disorders are combined with severe facial pain, and patients who enter our practice are complaining of the severe pain around his exterior acoustic meatus and around their cheeks and around their head, and all these structures, and even around their neck. So all these structures are interconnected, and we have to understand what happens, and we have to define at what level is responsible for the presence of this pain. Is this a muscle pain? Is this a pain provoked by the tooth contacts? Is this a pain provoked by the retrodiscal tissue, or this is an intracapsular disorder, or maybe this is pain which is involved in the severe bone resorption. So these levels have to be divided, and we have to make a step-by-step procedure to determine which kind of pain and where the origin of this pain is. So later we go to the facial examination. As I have noticed, we are examining the patient and look at the facial symmetry. And again, this beautiful girl has a facial asymmetry, and we can notice that her chin is deviated to the left, and we can notice that her left eye is a little bit larger, and we see that her nose is her alar parts of the nose are different levels. This kind of picture is necessary to have an emphasis on her occlusal plane of her upper jaw, and whether the lower jaw is deviated to the occlusal plane inclination, or it is deviated to the tooth contacts or to the muscle tension. So all these data have to be gathered before the final diagnosis. These facial photos are done and are gathered before we are stepping into the next phase of examination. The intraoral examination, these are intraoral photos, and we're seeing here already some occlusal paper marks, and this is the first level when we examine teeth, because we are marking her tooth contacts in her intercuspal position just to step into the next step and to watch her the distribution of contacts. The intraoral photos showing her excursions mark the contacts in the right lateral excursion. This is the protrusion. We see that her protrusion is not straight, and it is just at the photos. And we see that her that the mandible is deviating to the left, and that there are some contacts that are pushing mandible to the left side. And here, when we look at her left lateral excursion, we see that there is no pure canine guidance on the left side, and we see some group function and even contacts on the molar teeth, which has not to be present here because they are disturbing her normal function. This is how the T-scan occlusal analysis works. This is a handle of the T-scan, and we have a sensor that is used and that is placed in the patient's mouth, and the patient has to bite on the sensor. The thickness of the sensor is about 0.1 millimeter. We're asking the patient to bite on the sensor, and then we are making a record of the patient's movements, of the patient's contacts. This is the recording of the patient's centric occlusion. This is seen on the screen, and I'm turning it on. So we are seeing that the first contacts are present on the left side, and then the total force is going back, and we are seeing no contacts on the front teeth, and we see that these front teeth are not even occluding. This patient is a patient after orthodontic treatment, and when we are conducting orthodontic treatment, this is the common picture that we are seeing in orthodontic patients. We see that these are the force outliers showing the highest forces, and that these teeth are experiencing the highest forces in her occlusion. And maybe this is in some way this provokes her facial pain, which she is suffering from. So this recording was made during 2.0 seconds. This is a short period of time, and we're making recordings of her centric occlusion, of her multi-bite when she's clenching several times, and then we're making the recording of her functional movements. When we analyze T-scan occlusal recording, we're noticing the force outliers, the highest forces that the patient exhibits. And it was reported by Dr. Kirstein, whom I have mentioned earlier, that the higher is the force on the tooth, the higher is the muscle contraction, because masseter muscles are responsible for the tooth contacts in the posterior area, and the ligament, the periodontal ligament, works in the way that the higher is the force, the more contraction will be done by the masseter. And when the muscle contracts harder, then we get spasm and facial pain. The next step we're analyzing, I will go back, we're analyzing her right and left side balance. The patient feels comfortable when the contacts of the right and left side are balanced, where there is no prevalence on one side. So that's why we have to make this balance with this procedure approximately 50 to 50%. I have noticed that when I'm asking a patient to close his or her eyes and to occlude her teeth or his teeth gently, the first experience, the first contact that the patient is experiencing, his felt contact, is the same that the computer shows us. So when we're asking the patient his feelings, we have to consider this information, because it is the same as computer shows us. When I asked her to occlude, I saw that this contact was the first. And when we see the tooth contacting first, it means that this contact will persist during all the time that the patient occludes his teeth. It means that this only tooth will experience more pressure during all the occluding cycle, and this tooth is more prone to cavities and to complications of cavities, because it experiences more load than all other teeth. Then we will look at the force target and to the occlusion time. When we go back, we see those time intervals A, B, and C, D. These intervals are measuring the time that teeth need to come into occlusion. When we measure this time, we have this time graph, and the time during which the teeth have to come into occlusion should not exceed 0.2 seconds. When this time exceeds 0.2 seconds, the muscles have become overloaded, because they have to seek this position for the mandible to go into to come into occlusion. So this is a short outline about the T-scan analysis and how the system works. This reflex from the periodontal ligament is the only one in the human organism that works with only one interconnection between sensory input and efferent system, because these neurons, these sensory axons coming from the periodontal ligament, have the only interconnection in the midbrain, which goes directly to the chewing muscle, to the masseter muscle. And when we have this overloaded ligament, the chewing muscle, without any kind of interneurons, without any kind of supplementary interconnections in these midbrain structures, they go directly to the masseter muscle, and they influence directly the masseter, causing it to be spastic, causing its tone to become higher. So when we have an overloaded teeth, we have an overloaded muscle, overloaded especially masseter muscle. This is the recording of the lateral functional expansion. We should notice that the graph is divided into 4 quadrants, and we have to put our goal to make the canine guidance to be the main goal of any kind of treatment. When we conduct our orthodontic treatment, when we conduct orthopedic treatments, the canine guidance is the main thing that we should do, avoiding any kinds of working contacts on the side in the area of first and second molar and third molar. I'm not talking about the medial-intrusive contacts. There should be no medial-intrusive contacts on the opposite side, but the working contacts should not go further than the second premolar. They should not be present at the molar tooth, or first molar and second molar, because these types of contacts overload masseter and temporalis muscles, causing severe facial and head pain. More of that, I will go back to here, and what I'm going to show you is this lateral movement. Yes, the first contacts again started to be here on the first molar on the left side, and when I'm asking a patient These are the contacts. We have these overforced contacts, forced outliers in the area of the second molar on the left side. And from this point, this is the point when the teeth start to disocclude, we have to notice, we have to pay attention to those contacts that are persisting on her molar teeth. We're expecting, I asked her to go to the left side. We're expecting her left canine to be the dominant tooth in this excursion, and we're expecting no contacts on the in the lateral area. So she has started her lateral movement, and we're noticing that there is no dominating canine guidance, that she's going to her in the area of her first and second molar, and that these teeth are dominating in her lateral canine lateral guidance, and that there is about only 20% on the canine, and still these contacts are persisting. That what we have seen on her initial intraoral photographs, and this is what she's complaining for. She's complaining for a severe facial pain, and we have noticed her facial asymmetry and her left side being shorter than her right side. How we can utilize this T-scan analysis in our orthodontic practice? We have developed a special diagnostic procedure using these lateral movements and the time used by the patient to have its disclusion in lateral movements, and we have noticed that after when the patient is done with the orthodontic treatment, some patients complain of their relapse, and we see a small relapse in this post-orthodontic patient, remaining the diastema between the central incisors. And what can we do? We are analyzing her protrusive movement, and when we have written an article dedicated to this procedure, we have noticed that when the protrusion time is exceeding 0.5 seconds, there are remaining contacts that tend to make these anterior teeth go buccally, and these contacts are making these teeth rotate, and that when the disocclusion time, the time when the patient is going from the central occlusion, from the centric occlusion to the protrusive movement or to lateral guidance, when this time 0.5 seconds is exceeded, the patient is more capable to move his upper anterior teeth in a buccal direction. So the mandible is trying to push the upper anterior teeth in the buccal direction, and this is causing the buccal inclination of the anterior teeth and the presence of small spaces between the anterior teeth. Again, one of the aspects of the increased disocclusion time is when we see the canines being abraded. It means that severe abrasion of the canine area is due to the presence of the working contacts on the first and second molars. And when these contacts are persisting for longer than 0.5 seconds, it makes the canines being abraded. Canines try to take this function on themselves, but they're not. But they cannot do that because the contacts in lateral guidance, they persist on the molar teeth, which are not prone to conduct this movement. That's why the canine, when we see these signs, it means that there is a presence of the working contacts in the molar area on the ipsilateral side. So this is the procedure of the anteroposterior tooth contact adjustment, which we have developed with the use of the T-scan. The first thing we're doing within this procedure, we are diagnosing the presence of these contacts, which prolong the disclusion time, and then we are eliminating these occlusal contacts with the use of the computer-guided occlusal adjustment, which makes the risk of the orthodontic relapse less. There is a protocol which we are using with the T-scan occlusal adjustment procedure and with this anteroposterior tooth contact adjustment. So when we are seeing the disocclusion time more than 0.5 seconds, we are using occlusal adjustment in this sequence. Level 2 is the muscle palpation and the muscle examination. So we are going through all the levels, and all the levels within this 4-level concept are the levels which include structures within each level of the same origin and of the same function. So first level, we're examining teeth. We are trying to find the contacts, the occlusal contacts, which make some disturbances, which can cause the dysfunction. Then we go higher. We go on the next level of the chewing muscles. What we are doing, we're making the examination. This is the basic examination of the chewing muscles.
Open, wide.
We're asking the patient to open widely, so you see her mimics. Her eyes are showing us painful palpation on the left side.
Both sides. Close tightly, clench. Are palpating surface masseter.
So we're palpating different parts of the masseter. This is the surface masseter, and this is the deeper masseter.
This is
Temporalis muscles.
Nothing. Open. Are palpating radius of the mandible. This is medial pterygoid. Is it paining?
I don't even have to ask her her feelings. I am seeing all that she feels on her face.
Axillary tubercle, where palpating both lateral pterygoid. Nothing.
Temporomandibular joint muscles, chewing muscles. All 4 types of muscles, masseter, temporalis, and 2 pterygoid muscles, are situated within the inner muscle chain of the human organism. There are 10 types of muscle chains within the human organism that are working synergetically, and this inner muscle chain includes the tibialis posterior muscle. These muscles are going from the legs and from feet, adductor muscles of the femur, and the pelvic diaphragm, thoracic diaphragm. All these muscles going from the lower extremities to the upper extremities are all involved in the inner muscle chain, and the joint muscles are a part of the joint of this muscle chain. And when we are examining the patient, when we ask if his knee pains, if he feels any pain, we should consider the presence of the temporomandibular joint disorder, because pain in the pelvic region, pain in the knee region, pain in the shoulder region, these are all interconnected with the temporomandibular joint. And this is the first step diagnosis, the face and the pain and the patient's history. The anterior neck muscles, these are suprahyoid and intrahyoid muscles. These are neck flexors, and these are muscles that are making the mandible be opened. The posterior neck muscles are the extensor muscles that are working as antagonist muscles to the anterior. And when we ask the patient about his main concern, he or she may not even talk about his neck, but when we are asking further, when we have a TMJ problem, we will have a neck pain. And the neck pain is always connected with the scalenus muscles, and these muscles are connected to the vertebral artery. And when the patient is reporting about his about the dizziness and about the head symptoms, this could be connected to the occlusion of the vertebral artery caused by posterior neck muscles, which are the antagonists of the anterior neck muscles, which are prone to open the lower jaw. So this is the type of surface electromyography procedure that we are using in our clinics. This is one of the myographers. It is wireless. This is the video about the procedure. We're putting the sensors on the surface masseter and on the temporalis muscle. First step is the calibration of the appliance, of the equipment. So we're asking the patient to occlude on the cotton rolls. This is a patient biting on the cotton rolls. So you see she's clenching, she's opening a little bit and then clenching on the cotton rolls. This is the patient after the total prosthetic rehabilitation of her both jaws, and she had a severe headache. She was suffering, and we made also the electromyographic examination of her trapezius muscles, and she was reporting pain in her left trapezius. So we're examining all the structures, and we're trying to make the interconnections between the tooth contacts, between the functioning of the temporomandibular joint, and between the upper extremities region. We're closely using the applied kinesiology in our concept and the osteopathic treatment, and we're asking our osteopathic colleagues to help us with the treatment of these patients with temporomandibular joint disorders. This is the next step. This is the TMJ palpation, which also emphasizes on the signs of the presence of temporomandibular joint disorders. So when you look at her, we have noticed the left side deviation of the lower jaw. So, and the I'm going back.
So first, we're assessing the trajectory of mouth opening. Please open your mouth wide. We're measuring the amount of mouth opening, and we're measuring the trajectory of the deviation of the chin. The second step is joint palpation. We are asking the patient to open wide, open, and we're placing the fingers anterior to the exterior acoustic meatus, and we're palpating the head of the condyle.
You see her eyes, she's feeling pain on her left side.
Her condyle head, it is going laterally and is palpated through the skin. Okay, open widely, more, even more. And I'm feeling the movement of the condyle head.
And the patient have a deviation of her jaw. We're reporting her lateral condyle movement. We can palpate her condyle head of the mandible more on one side, and it indicates the side of the deviation. So with the clinical examination, we're examining the amount of jaw opening, the trajectory, the deviation, the deflection, the presence of clicking and crepitus while opening. This is a small girl, 7 years old, after the initial orthodontic treatment with expansion, and we see the deviation of the mandible. The central lines are not coinciding, so we see the deviation of the lower jaw, and we have made the joint vibration analysis. This is a non-invasive procedure which gives us the information about the presence of any kind of disorder within the temporomandibular joint. We can determine between the soft tissue and hard tissue disorders, and what we're doing, we're placing a kind of this appliance on the condylar heads of the patient, on the patient's face, and we have the diagram here on the screen, which gives us the amplitude and the frequency of the vibrations present in the temporomandibular joint. So here we have the average numbers gathered from 5 measurings, and here we can make the preliminary diagnosis of the presence of temporomandibular joint disorders. This is a flow chart when we can diagnose the type of the disorder within the temporomandibular joint. The classification used in diagnosing TMJ disorders is the classification which was introduced by Dr. Mark Piper. This is an American TMJ surgeon who have developed a unique classification based on the position of the temporomandibular joint disc, and he made a five stage classification, which involves the first stage. This is the disc situated on the 1 or 12 o'clock. The second stage, the disc is more anteriorly situated, and the other stages, fourth and fifth stages, are the stages when the disc is dislocated even more and more anteriorly. This causes the mandible to go up and to go distally, and to cause class 2 division 2. This is the MRI finding, the MRI picture, the inverted MRI in T1 view. We are using MRIs to diagnose the final disc position. This is the MRI of the patient in closed mouth view, and we see the disc between the temporal bone. This is acoustic meatus, and this is the condylar head. T1 type of MRI picture is defining more fat, and that's why we have to invert this picture, and it looks more white. All these white structures are more dense structures. These are bony structures, and these more dark structures are more infiltrated by fat and water. And so this is the disc position, and we see that the perpendicular line goes through the axis of the condyle head, goes straight, and the disc is dislocated more anteriorly on the 11 o'clock. So this is not a stage 1, this is a temporomandibular joint dysfunction. And during the opening stage, we see that the disc is located just on the surface and between the temporal bone and the condylar head. So in this picture, we see that the disc reduces when during the closing it was dislocated. During the opening, it reduces and it goes back on his original position. The level 4, and the final level, is the level of examining the hard tissues, and here we see the cone beam CTs of the temporomandibular joints. Originally, we are examining sagittal views, but the coronal views are maybe of the greater importance, because here we can examine and we can have a look of the symmetry of the condylar head positions, and the symmetry not only between right and left side, but the symmetry according to the fossa. And when we see the condyle head moving laterally, it may be a sign of the ligament laxity. So this is the summary of the 4-level concept. The first step is the occlusal examination, when we define occlusal contacts which can tend to cause muscle dysfunction. The next level is the muscle palpation, and we're determining what muscles are paining and what muscles are being spastic. The next level is the 3rd level of soft tissue examination. It involves joint vibrant analysis, joint palpation, and MRI examination of the TMJ. And finally, the 4th level is the level of the CBCT scans of the TMJ. It helps to examine the bone structures, which are the least, which we can involve, which we can we cannot do much about bony structures, but we can do much about soft tissues, muscles, and especially about teeth. So we can, when we go up to the level 4, this is the level when our dental intervention influences the structures the least. So when we diagnose and have a preliminary diagnosis of the presence of the temporomandibular dysfunction, we can avoid going to the level 4th and to get those complications from the bony structures. So the protocol is the patient's main complaint, the patient's history, teeth examination, muscle clinical exam, EMG, TMJ clinical exam, GVA, and TMJ MRI, and TMJ CBCT. So going from the easiest structures, from the level which we can influence the most, the teeth, we're going up and up to the bony structures which we cannot easily influence. You can find some videos on YouTube, and you can contact me in social networks concerning any questions on our instrumental procedures and on our examination procedures and our scientific and practical work. I'm very glad I had an opportunity to present this lecture for you, and thank you for your kind attention. Thank you very much. So I think that now we're going to have a small break. Yes? I will check the protocol. Thank you very much for your kind attention. I will check what we're going to do.